We are going to start back the afternoon with Ingo Helbig from the Children's Hospital of Philadelphia, and he is going to talk to us all about the genetics of Dravet syndrome.
Thank you. Do you guys need a few minutes, or is anyone listening? So Veronica already kind of warned me a little that I have one strike against me. I have like 2 more strikes, and then I'm going to get fired from the Dravet conference. Yeah, this happened. So my role in this meeting is to kind of give you an idea about the genetics of Dravet. And this may sound a little bit counterintuitive because we know Dravet is due to SCN1A. Quick disclosures here that I'm co-patent owner of an ASO therapy that may also be helpful for SCN1A at some point. And what I want to talk about here is a theme that we have developed in Dravet genetics over the last few years. And many people who don't really kind of think about Dravet and genetics think of this. The Dravet is due to loss of function variants in SCN1A. But what I want to point out in my presentation is there's much, much more to it. Yeah? There are the kind of variants of uncertain significance where we have to do lots of kind of bookkeeping and analysis to kind of make them diagnostic. There is the idea that we don't really think about SCN1A as a gene anymore. We think of this as a transcript, like splice variants. And then I'm going to briefly talk about gain of function variants. So I usually start my presentation with the history of Dravet syndrome and with the fact that actually the idea that we're here in this meeting room is something that's actually completely unusual and not what anyone would have expected 25 years ago. Yeah? What I want all parents to know, and I'm going to repeat this, what I want everybody to absolutely know is their G dot, C dot, and P dot. Yeah, and if you don't know what G dot, C dot, P dot is, I need you to pay attention right now because this is really important. Yeah? So I'm going to talk about VOSs, and then I'll finally talk about what I call the new genetics. This is the stuff that I'm going to tell you about that you probably don't often hear about. So let's talk about the history of Dravet syndrome. So let's go back to the time of Charlotte Dravet. And this was in the 70s and 80s. And kids with Dravet, they've always been around. We always had kids who had these very severe epilepsies. And if you kind of take all the knowledge away that we have right now, if you just look at how our Dravet kids present, this can actually be quite confusing if you take away the gene. And this is something I'm going to come back to at the very end when I talk about differences and heterogeneity and why we need to look at genomes in Dravet. So here, Dr. Dose called this a severe idiopathic generalized epilepsy of infancy. This was his kind of approach of kind of understanding this group of conditions that ended up being Dravet. Charlotte Dravet called this the SMEI, the severe myoclonic epilepsy of infancy. And then in Japan, there was this kind of condition that people called ICE-GTC, yeah? The intractable childhood epilepsy with generalized tonic-clonic seizures. And those are like overlapping circles. And the only thing that really kind of ended up being a real condition that is linked to a gene is Dravet syndrome. But let me pause on this slide a little bit, because this is something that will become very important again when we look forward, that Dravet and what we think of as a unique disease or as a kind of disease that is always the same, we need to kind of question. So there have been many historical speculations of what Dravet could have been. There were some people who thought, well, maybe it's genetic because there's so many affected first-degree relatives, so many siblings who have febrile seizures, so many parents who have febrile seizures. We know now that Dravet is genetic, but not because of this. Yeah? We know that it's due to de novo variants. There are other people who thought, well, maybe this is acquired. Many kids have seizures and this intractable epilepsy after their first vaccine. Yeah? Is there anything to Dravet that is vaccine-related? So Dravet syndrome ended up being genetic, but the initial speculations were actually wrong. So this is Peter de Jonge, who's the person who found SCN1A in Dravet syndrome in the class paper in 2001. Yeah, so it's 2024 right now. So SCN1A as a gene for Dravet syndrome is 23 years old. Yeah? And soon afterwards, people understood what a genetic diagnosis can actually do. First of all, it can demystify the idea that there is this kind of vaccine encephalopathy, this severe epilepsy that happens to healthy kids after they get vaccination. Those turned out to be people with Dravet syndrome. So Dravet syndrome, and especially SCN1A, is the most common genetic finding when we look at epilepsies in kids. It accounts for roughly 1/4 of all positive gene findings in childhood epilepsies. And it's really by far the most common genetic change. And this is now taken from a study that we published 2 years ago that looked at diagnostic tests in the US over a time span of 2 years. And what you can see is that there are really 300 individuals who had a diagnosis of SCN1A given during this time. And this is a slightly different way to look at this other than asking how many patients do we follow in Philadelphia or how many patients do we have in Chicago or Boston. This looks at basically all our Dravet patients. Many of them we don't even know. We just know that they are there because of the diagnostic test. So I'm going to talk about the gene discovery here. And I want to quickly break this down, what SCN1A means. So we know sodium channel number 1 and the alpha subunit, and here's a little cartoon on where SCN1A sits. SCN1A sits on the brain cell, on the neuron, and it sits in what is called the axon initial segment. And this is important when our brain neurons fire to kind of help get the electricity across. So there are many different SCNs. And there's SCN2A, 3A, 8A. Those are other epilepsies caused by sodium channels. And when you think about how this works, is that this is the cell. We see the chromosome, and SCN1A is on chromosome 2. Yeah. And here we kind of know the chromosome. When we look further, we look at the subbands, and in the end, you kind of get to the genetic code, the GATC letters, where we have a genetic change. So know your G dot, C dot, P dot. And I'm just going to remind this again because this is what I really try to hammer into everybody's head, that if you are a family member, a caretaker of an individual with Dravet syndrome, please know your genetic change. Because this is often not found in doctor's notes. This is often a PDF attachment in a medical record that cannot be shared. Make sure that you have a printout of this in your folder. And what this basically means is G dot, C dot, P dot means genome, cDNA, and protein. And this is just the coordinates where the genetic change in the SCN1A gene lives. G refers to the genome, C is basically what is called the cDNA. This is the translated DNA, and then P is the SCN1A protein. Yeah, so next time you're going to see your epilepsy doctor or your neurologist, just ask them, tell me my G dot, C dot, P dot. So why is this important? Here's one example. This is one of our SCN1A families where we had an SCN1A variant that was kind of identified almost like 20 years ago, very, very, very early. The way that this variant was described changed multiple times given how diagnostic labs update their nomenclature. The only reason why we were eventually able to find out that this variant was causative is because we had the G dot, C dot, and P dot. If we had just known that this was the protein change and we don't know what this would refer to, we would have been lost. On the other hand, Dravet syndrome is so common in the epilepsies. It is not common overall, but it is relatively well known for neurologists that people make wrong diagnoses. Here's an example of a little boy who had an SCN1A variant But when we looked at G.C.P., this variant was actually a relatively common variant in the US population. So this was not a disease variant, but this was a variant that was just happening in the SCN1A gene, and people withheld epilepsy surgery for this patient because they thought he had Dravet, and then after we kind of demystified this, we were able to get epilepsy surgery, and he became seizure-free. Yeah, this is one thing just to know, that with additional recognition, there's also a flip side. Yeah? SCN1A can be misdiagnosed, and I'll come back to this in a minute when I talk about gain of function. So what about the other Dravet genes? I'll make this very, very simple. There are none. Yeah? And I think this is something that you've heard from Dr. Urel already earlier. There are some genetic changes. They may look like Dravet syndrome, GABAG2, PCDH19, CHD2, KCNA2, or HCN1. But when we look at these patients a bit more closely, we see that their clinical presentations is really, really different. Yeah? From the distance, you may think about this as Dravet, but this is really kind of, first of all, very rare, and secondly, the presentations are differently. So, and when you ask the question, you have a child with, or a patient with a very typical Dravet story, what is the most likely diagnosis after SCN1A was ruled out? The answer is SCN1A. Yeah? SCN1A Dravet syndrome is so recognizable, so clear, that when you just look at patients who are tested negative, they may have been tested negative for the wrong reason. Yeah? So this is one of the few situations where we could say, let's actually go back and see whether we can get a second test or an updated test and find a change that may have been missed in the first place. So genetic testing is tricky. And what you see on the genetic test report, where you find your G.C.P., is just the long, or the very short result of a very long process. There's the DNA testing, then there's the analysis, and I think what many of you have heard about is the so-called variants of uncertain significance, or VUS. Yeah? This is unfortunately a type of genetic variation that we see quite frequently because we cannot be very precise. And what we're doing right now is we're trying to work with the official rule makers who kind of write these variant rules to get this more tighter and to really kind of make sure that we have fewer of these uncertain variants and can make more true diagnoses of Dravet, but also rule out the variants that we're not concerned about. So this is us. This is basically what is called ClinGen. This is the official NIH body that deals with these kind of variant criteria. And we're currently working right now to find rules that can be adopted by every lab in the US. So this was one of our kind of little victories a few years ago. There's OMIM, and in the past, Dravet syndrome was called an EIEE, an early infantile epileptic encephalopathy. And a few years ago, we asked them to actually drop this naming because this was very confusing, because Dravet is an epileptic encephalopathy. It is a severe epilepsy, but it is so much different from the epilepsies that present in the neonatal period. Yeah? And especially there are SCN1A epilepsies in the neonatal period, and we needed to kind of tease this apart, that there is no kind of confusion. So here is now the understanding, or here's now an idea why we need to rethink what SCN1A actually is. And I think you've heard about the antisense oligonucleotide and poison exons. And what SCN1A is in this kind of concept is not so much a gene that produces the SCN1A protein, but it is a gene that produces many different versions of the protein, and these kind of versions are being changed back and forth. And the reason why most individuals with Dravet syndrome do not show symptoms until the age of 6 months is because SCN1A is not there. And this kind of shows you, let me see whether I can use my PowerPoint here, my pointer here. This kind of shows you the reason why. So initially, until the age of 6 months, SCN1A is switched, and what is produced is not the functioning SCN1A protein, but a poisonous SCN1A protein. And it's not really poisonous, it just doesn't work. Yeah? So before the age of 6 months, SCN1A has a so-called poison exon, and there's very little SCN1A in the human brain. Yeah? Then by the age of 6 months, the poison exon shuts down, the exon 20 comes up, creates SCN1A, and then we'll see the difference. If a child has a mutation in SCN1A, then we see that the reduced presence of SCN1A causes symptoms. So, what is new about the genetics in Dravet syndrome? And how can we try to kind of think of this going forward? So I'm going to go back one slide, and I want to use this as an idea to really think about how we look at SCN1A. When you think about this idea here, that there's very little SCN1A in the first 6 months of life. Imagine this is 6 months here. I'm going to do this here too. Yeah? How can you have a disease with an SCN1A in these first six months? Yeah? If you have a mutation that makes SCN1A less functional, if you have a mutation that takes SCN1A function down, nothing is going to happen here. Yeah? There's very little SCN1A in the human brain. So the only way, and this is the language that I typically use with my trainees and with our genetic counselors and our residents, the only way that SCN1A can make itself heard in the first 3 months of life is through a gain of function. Yeah? And this is one of my very important messages, because we have many patients that we think are misdiagnosed. They have an SCN1A disease, but they do not have Dravet. And this is the next thing I want to talk about: loss of function versus gain of function. So this started out in 2017. Yeah, so almost 7 years ago, when the Australian group that I trained with described an SCN1A genetic change. Here again, C dot or G dot C dot P dot. This is a P dot, and this P dot describes exactly where this change is. This one is the SCN1A protein flattened out with an ironing board. Here. So this is at position 226, and there's a T that has been switched to an M. There's a spelling mistake in the SCN1A change. It is not a change that breaks the entire protein. It is just a small change. And what this change does is that it kind of increases how much sodium can pass through the SCN1A channel. And if you have too much sodium passing through, the channel works too well, and this is called a gain of function. So the reason why I'm showing you this slide is because this gain of function change, we find this at the very same position in other sodium channels, SCN2A, 3A, 8A. So this is a very conserved spot here. And sometimes we can almost make some inferences from genetic changes found in other genetic epilepsies. So there are many SCN1A gain of function changes have the same change in SCN2A or SCN8A. So summing this up, there is more to SCN1A than Dravet syndrome or GAPS plus. There is gain of function. Yeah? And if you go back to the slide initially, from here, we're getting a very good idea of when this would happen. So SCN1A gain of function happens here, happens very, very early, yeah? In the first 6 months of life. So this is something that we actually looked at in our own cohort. And what this here is basically is just an overview of every single patient encounter in our medical records that we've seen in our patients with SCN1A disorders. Here, the x-axis is a patient age. This is 0, this is 10 years. And those are just patients that are being stacked by their first visit at our center. And then every single line is a patient. And everybody who's red here is a patient with SCN1A. So what we see here is when we just kind of then look at the time when everybody had seizures. You can see this is like 1 day, 6 months, and 10 years. Many, many children with Dravet syndrome had onset of seizures here. So this is the very typical 6 months to 9 months time frame. Yeah? But there are actually quite a few individuals who had seizures much earlier, as early as the first day of life. Yeah? And what all these individuals had, so those are 4 individuals here that we kind of identified at our center within 2 years, and they had the same genetic change. Yeah? This was not a stop change. This was the 1336 change, an R2Q change, and this change is a gain of function. Yeah? So this is important because gain of function, think of this as the anti-Dravet. Many things that we kind of think are contraindicated in Dravet syndrome, sodium channel blockers, they are very important in this case because this can help them become seizure-free. So, SCN1A beyond Dravet syndrome. There are SCN1A-related epilepsies that are due to gain of function, and they've only really been recognized in the last 2 years. I think when I spoke 2 years ago, this was the first time that I brought this up. And I would like to basically make the point that this is really a finding that we find in basically almost like 10% of people with unclear Dravet syndromes. This is not limited to specific epilepsy syndromes, and it is really, really under-recognized. So please think about gain of function in every individual with a Dravet syndrome that is atypical, and you can only have a gain of function if you have a certain missense spelling, so you don't have a stop mutation, but you have a little change. And every atypical change is highly, highly suspicious of a gain of function. And I'm happy to kind of answer some questions about this afterwards, but this is what everybody is going back to now and say, is this patient who has alleged Dravet syndrome and had epilepsy starting at 1 month of age and now has a movement disorder. Is this really a Dravet syndrome? Or could this be a hidden gain of function where I can actually use sodium channel blockers that I wouldn't have used otherwise? Yeah, age of onset is important, so those are often epilepsies before the age of 3 months. And then again, all these medications that we're trying to withhold from our Dravet population can be used here. So now comes the new thing that I'm actually very excited about. And this is the genetics of Dravet beyond SCN1A. And what I'm going to show you here is a large family with GEFS Plus from Israel. So this is a family that we recruited in the vicinity of Jerusalem in 2014. And all these different colors represent different epilepsy presentations within what is called the GEFS Plus spectrum. So you don't really hear too much about the GEFS Plus spectrum these days, but this was initially how SCN1A was discovered. It wasn't discovered in Dravet syndrome, it was discovered in these large families. And you can see here, those are basically patients with febrile seizures and absence seizures, patients with febrile seizures and atonic seizures, but in contrast to Dravet syndrome, they typically have a normal EEG, and they eventually outgrow their epilepsy. So it's a relatively mild epilepsy. However, the reason why this family came to our attention was because of this little girl, and this little girl has a very typical Dravet syndrome. So what we have here is the extreme of what SCN1A can do. We have here our proband with Dravet syndrome, but then this very same SCN1A mutation, this causative SCN1A mutation, causes all these milder epilepsies and doesn't cause any epilepsy in 3 individuals in this generation, like these individuals here who have this dot. Those one here, yeah? So we have this big family where we have a very clearly explanatory SCN1A mutation, and we see the entire range, from Dravet syndrome to people who are unaffected and everything in between. So this was our first kind of insight into what is happening here. And the answer behind this family very likely is that there's actually a second SCN1A mutation in this family that runs in the family almost like counterintuitive to what the SCN1A mutation does. Yeah? So we know that there's a protective variant that all these individuals who are unaffected, they have some sort of like a second protective SCN1A variant. This was the first time that we ever found this in humans. There are some examples in mice, how this can happen, but this was the first time that we found a kind of really suggestive modifier gene. This is something that is really, really unusual, and it's probably not the case in many families, but this kind of told us that there's lots and lots of things to look at when we think about modifiers. Yeah? And you can think about this in the following way. There's Dravet syndrome and the causative SCN1A mutation. There's not a doubt that the SCN1A mutation is the cause, But the way how this mutation expresses itself, whether this mutation causes a severe epilepsy with intellectual disability or a epilepsy that can be managed with moderate intellectual impairment, this is not due to the SCN1A mutation. This is really due to other factors. So, why can a single variant in SCN1A present so differently? And I want to go back to this kind of very first slide that I had with this world map, where I showed you how all these different physicians in the 70s and 80s didn't actually get Dravet syndrome because they couldn't really see the pattern, you know? And I think now, after we have 20, 25 years of really kind of seeing the pattern, maybe it's time to kind of loosen this a little and appreciate how our individuals with Dravet syndrome are really different. Yeah? People with Dravet are different with regards to seizure burden, how much seizures they have, how they respond to medication. We have people who became seizure-free on Epidiolex, but many people with Dravet are not. Yeah? There's quite a difference when it comes to developmental outcomes and comorbidities. Yeah? And we know that the SCN1A mutation itself is not the answer. There's a small asterisk there. Yes, there are some families with GEFS+ who have a very mild SCN1A change. But this is not part of what we're talking about here. This is not what kind of defines all the variation that we see in Dravet in our kids. This is just very a 0.1% issue. Yeah? And what you've heard already today is that there's quite a strong impact of what is called the genetic background. So whether I'm tall or whether I'm not so tall, whether I'm kind of have a certain hair color or whether I have hypertension is driven by many, many different genetic factors that come from my mom and come from my dad, and we call this polygenic risk. This is the genetic background. This was somewhat of a, like say, dream or a hypothesis only 10 years ago, and now we can actually measure this. Yeah? We know, for example, that common epilepsies, not Dravet syndrome, but childhood absence epilepsy, they are largely due to these common factors. Yeah? And we can measure them, and we can see how much each individual has a certain burden or a certain risk for epilepsy or autism or comorbidities. Yeah? And what we're thinking right now is that this is really what may explain much of the difference and may give us completely different insights into comorbidities and expression of Dravet. So what I was very kind of proud and thankful for is that the DSF awarded us with a major research grant in 2023. And this was a grant for Dravet genomics. So our task right now is to understand the genetic background in Dravet. And we want to do this in 500 individuals. And I'm going to show you the first part here. Because when we look at, I'm actually going to take this away. I'm going to make you wait a little. Is this, Veronica? Oh, shoot. Okay, this was just strike two. Okay. It didn't actually go back. Sorry. It should go back. Okay. So I'm going to have you wait a little. Because before we kind of dive in and can do genome sequencing, and by the way, I want you all just to step by our booth because we need everybody's genome. This is the first time that at a conference really asking for something. I'll get back to you on this in just a second. But let me do the following. The reason I'm going to make you wait is because there's no such thing as doing genome sequencing in Dravet syndrome without actually understanding how our individuals with Dravet are different and how we can actually measure this. Yeah? And so what we have been working on for the last few years are methods to somewhat look at disease presentations over time and measure them objectively and compare them, largely taking this from the electronic medical record. And this is now one of our first results here of our kind of first little kind of sub-cohort of these 500 patients that we're going to analyze. And this is Anna. Anna is back there. Anna, just wave your hand quickly. Thank you. So Anna's our kind of new genetic counselor. She hasn't even started yet. She's here just on her own volition. Yeah? And what we're looking at here is something that I want to walk you through, because I want you to kind of keep this in mind, and I'm going to show these things again in two years. So don't tell me that you're not prepared. Yeah? So here, every little bar is a single month. This is age 0. This is birth. This is like 60 months. Yeah. So 5 years. And then what you see here are different colors. So the colors represent seizure frequencies. And if you zoom in, you can see this is this bar here is every single individual in this cohort, 55 individuals. And for every individual, we have followed this individual through on a month-by-month basis, giving them a seizure frequency to the best of our knowledge, from medical record, from patient interviews, from the electronic medical records. Those are called alluvial plots. We've done them now in several conditions. And what is quite interesting here in Dravet is that there's actually quite a bit of data there. Yeah? And this is one of the kind of messages that I sometimes have at conferences. Data on Dravet syndrome is not rare. It's just that we don't understand it. Yeah? This is called the real-world data. This is data that we're actually taking from existing patient data. And here we have 350 patient years. Yeah? We kind of looked at seizure frequencies and medications and development over 350 patient years, and this is just a subset of a cohort. So when we look at this, we actually get some very interesting insights. Yeah? First of all, this is the first time that I've seen that much yellow here, and yellow means monthly seizures. So we know that many people with Dravet have most commonly monthly seizures. Yeah? This is in contrast to other epilepsies where we have daily seizures. And then the contrast is quite striking, because when Anna reconstructed this, we realized that at every single interval here, no matter whether we're looking at this early, and then you can see why is there something at the age of 1 month, those are our gain-of-function patients, but even here or here or here, there's at least one, and often 2 or 3 individuals who are either seizure-free or who have daily seizures. Yeah? And this Dravet spans the entire spectrum. No matter where we look, we have this broad range that ranges from complete seizure freedom to multiple daily seizures. Yeah? So this is this mystery that we're trying to solve. What explains this difference here? Here's the idea about kind of development that we looked at. Yeah? Those are kind of numbers that you already heard earlier, but now we have them basically reconstructed here. We know that the vast majority of our individuals have developmental differences. Yeah? We know that basically they have abnormal EEG findings. These abnormal EEG findings are often most common at the age of 4 years, and then they kind of get lower. Yeah? And those are these kind of ways how we can create these standardized phenotypes in addition to the genetic data that we're going to get. So I think I'm making up a little bit for the time. Can I take one strike back maybe and only be with one? Okay, thank you. So I want to quickly kind of thank my team who's here. So this is, if you, on the opposite of this wall is basically our little booth. Yeah? This is Johanna and Anna. Johanna is one of our kind of research assistants who kind of leads our recruitment here. Anna is our genetic counselor. I want to also point out Arjun, who is one of our students who joined us here, and Sarah, who's our nurse practitioner, who kind of runs our, what we call Dravet Genome Project. And we really have this goal to genome sequence 500 people with Dravet and to rebuild their medical histories over long term so we can ask these questions. What is driving these differences? What is driving the response to a certain medication? Why is one patient has very severe autistic trait versus the other person doesn't? Yeah? So those are these data sets that we're trying to build. And I would really kind of ask everybody who's interested in this is to stop by our booth, by our table, and just help us with the research. So I'll have a little bit of time left for questions. Thanks everybody for giving me the chance to kind of give you the update on Dravet genetics. Okay, this is where do I start? Over there. Okay, you guys have a microphone. Very good. And this is really, I cannot see you guys because there's quite a bit of bright light there.
I'm here.
I see a hand.
Okay.
Yeah.
I was just curious because you were discussing how there's very little evidence or presence of the SCA1 gene expression prior to 6 months.
Okay. I don't think the audio is on. Or would you mind just checking?
Does she just need to speak louder?
Okay, just
That'll
okay, just
help?
maybe if you don't mind, just kind of speaking a little bit louder.
Okay, sorry.
Don't be shy. Yeah.
My question is, will Dravet ever be something that we could put on a newborn screen that could be tested like any of the other metabolic diseases that we test for on newborns? Because
Would you maybe just mind repeating the question, because I didn't understand
I'm
you.
wondering if Dravet would be a disease that we could put on the newborn screen that all
Oh,
infants
okay,
receive?
yeah. So could we put Dravet on the newborn screening? So I have actually two opinions of this. So the advocate in me says absolutely yes. Yeah, so there's no doubt. The more like a skeptical scientist in me says, well, it's a condition where we're actually relatively good at discovering this early. So people might disagree when I say this, but often when we think about the current genetic testing options, in many places we can get the Dravet diagnosis through sponsored testing relatively soon. Yeah? And especially when we think about newborn screening, I think there's going to be a push in a few years that these changes will be discovered. What we don't really know is how you handle this preemptively. And we've seen this in many other conditions, that it's actually quite a big difference on kind of making a diagnosis on someone who has symptoms early and following someone who is at risk. Yeah? So this is somewhat an unexplored space, but I think this will definitely happen at some point.
Hi.
You guys got to work on your microphone skills.
My kids are adults.
Yeah.
Kai is now almost 27. Sierra is 30. And unfortunately, the SCN1A test wasn't available until 2006, when Kai was 8.5 and Sierra 12.
Yeah.
And sure enough, they came back the exact same mutation. And then we finally got their father to participate, and he came back. It was paternally inherited. So once we had that, we were able to better target, what the kids were on. Kai's on the Dravet end. Sierra has always presented less impacted than him. And I'm really starting to think now, and I hope they're not too old for your study, because I would be happy to have them participate. Lamictal came out when Kai was maybe 5 and Sierra 8. And it was kind of the newest, latest, and greatest. And I was like, oh, less side effects, put him on it. Kai just got worse and worse. With him, we had done Tegretol, and then, we had something else that didn't sit well with him. But then the Lamictal, and Sierra was fine. She has taken it more than 20 years now. And both see a neuropsychiatrist, and the neuropsychiatrist is like, don't get her off it, don't get her off it, and she does just fine. Kai cannot have any sodium channel blockers. Tegretol, what else? The Lamictal, we tried Xcopri. I'm just like, look, it makes it worse. So I guess I have always wondered why she can tolerate Lamictal and he can't.
Yeah, so this is always a little bit tricky, because it's hard for us to really kind of comment on specific situations, but I think the situation you're describing is something that's relatively common in Dravet, that we sometimes have two people in a family and they do exactly the opposite. Yeah? To answer your first question, no one is too old for our study. So feel free to just kind of come to our booth afterwards, yeah, because then our team can kind of tell a bit more about how to participate. To maybe phrase this a bit more generally, we have 2 siblings in a family, and we have Lamictal, which is the almost like toxic drug for SCN1A. And one patient with SCN1A has side effects, and the other one doesn't. What is happening here? So, and I'm going to be quite honest in saying I don't know. And what I'm also saying, I'm even more than saying I don't know. I say I wouldn't trust any explanation that anyone gives you, because we haven't done the research yet. Yeah. So this is something why we actually want to have these larger projects looking at genetic background, looking at other variants, because I could come up with probably 20 different explanations why this may be the case, and I'm just basically freewheeling and spinning. Yeah, so this is really something that is there. We see vast differences. You've seen the family tree that I gave you within families with SCN1A, and right now we don't understand what this is due to. And this refers to seizure severity, but also medication response. I think they're trying to play a trick on us. Yeah, there's some scheme going on here. Yeah, yeah. Yeah.
Can you maybe explain why you feel 500 patients might be sufficient to give us some results?
Yeah, I'm happy to. So this is like, you guys could see this was not a real question, right? This was like gotcha. Yeah. So. And I'm going to actually explain where the question comes from, and then I'm going to give you the answer. So the question comes from this idea when we think about genetics, and when people think about common genetic factors, they often require studies of thousands, if not tens of thousands of people. So when I mentioned earlier that we have genetic factors that explain, for example, childhood absence epilepsy, those were studies that we've done in 10,000 people. Yeah? However, we don't need to do these studies in Dravet. We just need to apply the results of these studies to a sufficiently large Dravet cohort. So we're not actually trying to kind of do an association study, just technical language, but we actually want to apply existing polygenic risk scores to a cohort, and this is definitely sufficient. You can do this in cohorts of like 100 and 200 people. Okay, I'm going to take one more question with a working microphone.
Thank you for your talk. It was incredibly illuminating. One of the takeaways I had, and maybe it's wrong, is that SCN1A is the problem. I have heard since my daughter's diagnosis that there's roughly 20% of people who do not have an SCN1A modification that do have Dravet. Is that purely due to insufficient genetic testing or wrong genetic testing, or how do we explain those 20%?
So, and I was actually realizing when I made my point that there's very little in Dravet at SCN1A that I was kind of throwing a little bit of a hand grenade into the existing literature. So I think the idea, I think this is probably a mixture of different things. I think if you go back maybe 10, 15 years, this was probably due to insufficient testing and due to, for example, tests that may not have found the genetic change. So we know that there are some changes that would have been missed that are small deletions in the gene. If you have an exon missing, and if you use an older sequencing technology, you may not actually find this. Yeah? I don't think this number is true as of 2024. I think the number of truly SCN1A negative people with Dravet syndrome is very, very small. Yeah, so we have seen 200 people at our center, and I'm yet to see a child with a typical Dravet syndrome where we can confidently say that SCN1A has been ruled out with modern technologies. This may happen. Yeah, there can be other features that present like this, but many of the other conditions, PCDH19, they look really differently if you kind of see patients in clinic. And I think we have time for 2 more questions. Yeah.
Okay, so my son Ryan passed away 22 months ago, but he was SCN1A mutation with gain of function. So I'm staying on as an ambassador because he was 16 and a half, so I feel like I have a lot of knowledge to share. What would you tell me, like when I talk to all the parents and later and stuff like that, like what are the things that you would tell me, per se, if they said something that was like Ryan? I mean, I hear everything you're saying. I'm getting the questions about the testing.
Yeah.
He wasn't even diagnosed till 6, and then a bunch of doctors did a paper and came out with that at like 2018. A lot of good doctors. You might even have been on the paper for all I know. Wasn't very many kids.
Yeah.
There's not very many of them.
Yeah.
So I don't know, maybe if you just had something that I should bring up if that comes up.
Yeah, so first of all, I'm sorry, yeah, and this is often something that really is a big issue in the Dravet community, and I think you've heard earlier the kind of numbers on SUDEP, and this is one of the things that really needs to be explained in the same way as drug reaction or drug response. I think what I would kind of tell families and providers is that the landscape has really shifted. So Dravet syndrome is something that most emergency rooms right now know, yeah? And where testing has become quite common. I maybe want to give you one example. So I've been giving talks at the epilepsy conference for the last probably 10 years. And there's every second year I have to give a talk in front of adult neurologists. So adult neurologists were kind of traditionally very kind of opposed to genetic testing. Yeah, there was always this question, what does it help? Does it change any management? And even in the community of adult neurologists, they don't ask this question anymore. This has really changed from almost like being antagonistic and smiling at me on the way out to actually kind of being happy that they hear something about this. So the message is getting through, yeah? And what of course is difficult is that SCN1A gain of function. And maybe this is one thing where I would really maybe think about this more broadly. I think SCN1 gain of function also belongs in the Dravet community, yeah? Because there's no one else to take this on. And I think this is just this rare exception is something that will become more common. And there are many rare diseases at the same frequency as SCN1A gain of function, and we've made them known and we've made them understood. And so maybe this is the message I would say, is that things have changed and there's an entire community of people out there who try to kind of push this message through. Okay, thank you.